Bismillahirrahmanirrahim. Welcome to my channel with the four part of root canal treatment, that is obturation. I have already discussed the main parts of RCT, that are access cavity preparation, working length and canal preparation. So what is obturation? It is the last part of RCT in which we fill the canals and cavity with filling materials. It is three-dimensionally filling of the entire root canal system with biologically acceptable materials. The materials used for filling should be biocompatible. Usually it is obturated with core material and minimal amount of sealer. Now the question is, why is root canal obturated? Following through cleaning and shaping, the root canal is obturated to provide airtight seal. Obturation prevents multiplication and ingression of microorganisms through the coronal leakage. Also prevents leakage of tissue fluid and bacteria from the interconnection with the gingival and periodontal pockets. Criteria for obturation. The root canal should be obturated when there is absence of pain and swelling and there is no tenderness to percussion. The canal should be free of any infection and it should be dry. Also, the canal has to be medicated for at least 1 week. Obturation shouldn't be carried immediately in a cases of apical periodontitis or a tooth with excessive exudate and purulent discharge. Obturation requires obturating material and sealer. The core material for obturation is gutta-percha and silver points. These are gutta-percha. Gutta-percha is composed of 18 to 20% trans isomer of isoprene, 59 to 76% of zinc oxide, 1 to 18% radioopsifiers, and 1 to 4% plasticizers. The advantages of gutta-percha are its compatibility, inertness, dimensional stability, and tissue tolerance. It is also have a property of readily opacity. It becomes plastic when it is warmed. The disadvantages include lack of rigidity and lack of length control. The known solvent that it can dissolve the GP are chloroform, xylene, and eucalyptus oil. Also, it can be sterilized in 5.25% sodium hypochlorite for 1 minute. Silver cones. In 1933, Jasper introduced silver cones. Their rigidity made them easy to place. However, their inability to fill the irregularly shaped root canal system permitted leakage. The disadvantage of this system are leakage and corrosion. That is, when it comes in contact with saliva or tissue fluid, it causes corrosion, and that will eventually cause cytotoxic and pathosis, leading to periapical infection. This is silver points kit. Root canal sealers. These are used in combination with gutta-percha to obturate the canals. There are 6 types of sealers that are used to obturate the canals. That include zinc oxide sealers, calcium hydroxide sealers, glass ionomer, resin sealers, silicone based, and urethane methacrylate sealers. The sealer include liquid and powder portion. It should be combined in order to make homogeneous mix. The final mixture should be free of streaks. The final mixture formed is then applied to the tip of GP, that is gutta-percha, and then it will be transferred to the canal in order to obturate it. Before the placement of master gutta-percha, it should be make sure that the length of the GP must correspond to the final working length of the canal. Techniques of obturation. The 2 basic criteria that are used for the obturation of canals are lateral compaction and vertical compaction. First, I will discuss lateral compaction. The main objective of lateral compaction is to fill the canal with GP cones by compacting them laterally against the sides of the canal walls. For this purpose, Two main types of spreading instruments are used. There are long handle spreaders and finger spreaders. I usually prefer the finger spreader because it has better tactile sensation. The spreader should fit into the canal within 1 to 2 mm of its working length. If it doesn't fit, it means that more shaping is required because the apical size and taper is inadequate. Similarly, the master apical cone of GP should exhibit a tug back or resistant to removal when it is placed in the canal. The whole process of lateral compaction is shown in this picture. In the first one, you can see that the GP is coated with sealer and then it is placed in the canal. Afterwards, a spreader is used which helps in providing more space for another GP that is to be placed within the canal. Also, it helps in the lateral compaction of the previously placed GP. This process should be repeated until the whole canal is filled with GPs and doesn't have any space for more GPs. Once the obturation is done and it's satisfactory, the excess GPs should be removed by using a hot condenser up to a level of cemento enamel junction. Lateral compaction is gold standard. The main advantage of this technique is its excellent length control. However, this technique may not fill canals irregularities. It is the most commonly used procedure. This is the pictorial representation of the whole process of lateral compaction. It's a kind of summary. So anyone who is watching this video can go through this slide to understand the concept of lateral compaction. This slide explains the radiographic evaluation of obturation. Vertical compaction was introduced in 1965. It's particularly used in condition of internal resorption as it can fill different irregularities. The cone selected must be slightly shorter than the preparation. Obturation. Sealer is mixed and applied in the canal with the help of an endodontic file. Afterwards, the master cone should also be coated with sealer and is placed in the canal at desired length. This is how the plugger is used to condense vertically the GPs. The advantage of vertical compaction is that it fills the canal irregularities and accessory canals. The disadvantage is that it has a risk of vertical root fracture. It also makes it difficult to vertically compact the GPs in the curved canals. Afterwards, the cavity is restored with restoration material. So this was all about RCT. I hope you like all the videos. Don't forget to like and subscribe my video. Thank you.